Okay, I think we'll get started shortly. I'm waiting for a few more pictures on the screen. There's Joe. Carol, we're waiting for Chase. So good morning, everyone. Welcome to the session on Medicaid waiver renewal and the future of ACHs. We've had a few tech issues. That's why we're starting just a few minutes late, but kudos for all those masters behind the scenes who have made this work. I mean, it's amazing. So I have to say thank you right up front. So my name is Linda Evans-Parlett, and I'm the Executive Director of North Central Accountable Communities of Health. From North Central Washington, notice the apple trees in the background. That was just taken yesterday. We have a great panel for this session, and I look forward to the discussion. But to begin with, I'm going to do what we've done in all the sessions, just go through a little tiny bit of housekeeping activities, and I'll probably just read them to speed things up here. So before we get started, I just want to remind everybody that the audience is muted and your video cameras are turned off. And you'll only see the panelists on the screens and the slides when they are shown. If you are having technology issues, please put that in the chat. There's only the option to chat the panelists and not the entire audience. And our tech gurus will make sure that your chats go to the panelists because we will have questions later. If you do have questions for speakers, use the Q&A box and we will do our best to get as many of those questions as possible. Both the chat and the Q&A function should be at the bottom of your screen. And we are recording all sessions, and copies of the slides will be available on the websites after the third day, and that's today, of the symposium. And that is www.washingtonach.org. And now let me quickly introduce our panel, and you will see that the bios for both of them will be put in the chat. Joining us today from the Washington State Healthcare Authority is Michael Arness, who is the Deputy Policy Director, and also Chase Napier, who is the Medicaid Transformation Manager. And representing the ACHs, we have Joy Leroy, who is the Chair for Elevate Health, that is in Pierce County, and Carol Mosier, who's the Executive Director for the Greater Columbia ACH. And we're going to start this session with a presentation from the Healthcare Authority about the Medicaid waiver renewal, followed by a discussion across and with our panelists, and then a question and answer from the audience. So again, please remember to post your questions to the question and answer box, and we'll get to as many of them as we can. Now let's begin with an overview of the Healthcare Authority's goals and plans for the Medicaid waiver renewal. And Michael and Chase, I'm going to turn it over to you.
Linda, good morning, and thank you so much. And thank everybody at the symposium for inviting us here to talk a bit about the Medicaid Transformation Project renewal. I'm Michael Arness, the Deputy Policy Director, and I'm going to start off with a brief description of what the Medicaid Transformation Project is. And then I'm going to hand it over to Chase to talk a little bit about the renewal update. And Linda, just a quick note, I know that Chase is being kicked on and off. And so Chase, if we get to your part and you're not there, I'll take it to the close. A lot of rain here on our side of the state, Linda, my apologies. So the Medicaid Transformation Project, if we can go to the next slide, has been around since 2017. And it has 5 major components to it. I think as most people know, it's running through 2021. And the first part, and the part that is most germane to today's conversation, is the transformation of care in local communities through the Accountable Communities of Health, the ACHs, as well as the Indian healthcare providers that have their separate transformational activities. And of the $1.5 billion 5-year transformation project, this first topic here is about 1.1 of those $1 billion. And it is a significant change in the way the state looks at performing transformation in local communities. And it has been building a strong partnership between the accountable communities of health, the ACHs, as well as the Healthcare Authority. And let me go through the next four rather quickly because they are significant to transformation, but not so much to our topic today with working with the ACHs, but there's long-term services and supports. And we put in two programs that are innovative, the Medicaid Alternative Care Program and the Tailored Supports for Older Adults, the MAC and DSOLA programs. And the goal of both of those is simply to keep clients and caregivers in their homes as long as possible before the care needs to move to a different setting like a facility. And the second one is foundational community supports, and that focuses right on stable housing and employment for clients. And glad to say that that particular program is now over 20,000 enrollees. So we're making a significant impact, and we've had some early results with foundational community supports measured by a lot of our experts, and some real good results initially on that particular program. Again, focused right on housing and employment. And then the next two are treatments for substance use disorder and mental health in facilities around the state. And the primary purpose of these was to make sure that we could draw upon federal money to pay for the services and the treatments that are performed in IMD facilities around the state for substance abuse and for mental health. This is a big boost to the state and a big boost to building capacity for treatment of these two conditions. And again, very much appreciative from our federal partners to help us pay for these services. And these were two that were put in rather recently. So we're still observing how they're doing and observing the impact. And if I could go to the next slide, this is where I want to talk a little bit about a one-year extension and then tee up a little bit about the renewal before we turn it over to Chase in a few slides here. But at the Healthcare Authority, with support from our accountable communities of health partners, we have submitted a one-year extension for this 5-year project. So we are already thinking of this as being a 6th year of the Medicaid transformation project that would run through 2022. So no longer would the Medicaid transformation project end at the end of 2021. We would continue through 2022. The reason for this, of course, was the COVID-19 pandemic, and it was disruptive in our efforts. We also pivoted with our partners in the communities, the ACHs, to respond to the pandemic, but it also disrupted some of the transformational plans that we had put into place, and also a real tilt towards how are we going to make some of these items sustainable. So we would so we can do that and work on the implementation, and then we're working on doing the 5-year submittal. So let's go to the next slide because Chase will talk a little more about that. And what we are going to be talking about on the next slide is just that we have not a lot of changes in our two areas, the foundational community supports as well as long-term services and supports, but also the area with the IMDs, facilities, services, not a lot of changes in those as well. And you'll see that on the next slide when we get it forwarded. But the real area of concern that we want to talk about is the initiative 1. And so if we could go to the 5th slide, please. These are some areas that we have some additional initiatives, and I'll just point out 3 of them because they have some legislative concerns. So that's the reentry initiatives, as well as the continuous enrollment for children and the expanded postpartum coverage. And so if we could just go to the next slide so we can get into the meat of our topic today. And Chase, if you're on, please take it over so we can talk a lot about the evolution of Initiative 1.
Thanks, Michael. Can you hear me okay?
Yes.
Perfect. Yeah, so we want to spend more time now talking about the evolution of Initiative 1 and how that relates to the future of ACHs and our ongoing partnership with ACHs. So this is a high-level view of where we're at and what we've been planning. We've been in a lot of conversation with the ACH executive directors and CEOs, a lot of planning at the Healthcare Authority and with our managed care organization partners. So this reflects some of those discussions. The high-level strategies really focus on health equity, health-related social supports, and whole person care. And we do think that there's a really strong role for accountable communities of health going forward. We've valued the partnership, and there are just a few kind of core functions that really stand out as valuable and work that we should continue to build upon. And that's the neutral convening role that ACHs play, the really unique community engagement that ACHs have supported and developed mechanisms for, and provider supports. And that's some of the clinical provider supports and relates back to the session we just had on integrated care assessment, but also the community-based organizations who we've heard a lot from during this symposium, and just the really strong partnerships that ACHs have developed with their communities. So those functions really, can support ongoing work through our 1115 renewal. And we, want to partner with ACHs and continue to coordinate between the Healthcare Authority and the regional ACHs across the state. So there are some specific activities we've been thinking about and planning around. One of them is the work to continue building upon the integrated managed care. As we all know, our state has fully integrated the behavioral health and physical health through managed care, but there's a lot of work to do still on clinical integration. What does that actually translate to when a client's trying to access services? And so tying back to the session just before us, we want to continue supporting clinical integration assessment. We think that's going to reveal a lot of opportunities for provider supports through coaching or technical assistance. So a lot of work there and how we help providers move along the continuum to integrate care. So that's one focus. The other is community-based care coordination. This is work that ACHs have been involved in over the past few years. We really think that there's an opportunity to keep the system connected, to keep organizations coordinated and aware of client needs, aware of progress that's being made. So this is a body of work where we think we can support referrals, support coordination, support access to the appropriate information, and ACHs have some really great lessons learned and work to build upon. If you've heard of the community-based care coordination hub model, that's really what we're talking about here, how we can use regional hubs to really provide some centralized support and provide kind of a no wrong door for clients that need access to community organizations, social supports, and to do that in a really cohesive way where we're able to share information, like I mentioned, and make referrals and even a way to better standardize what resources are available and how do we make those resources known to different organizations so that referrals can be made. So some really exciting work there that we're interested in continuing. And then related to that in a way is the exploration of different payment strategies to address health-related social needs. And specifically, a couple of concepts we've been looking at are in lieu of services and value-added services, and I'll talk about that in a second. And then, of course, we do envision continued funding for tribal-specific projects, which could, relate to some of the same topics around health equity, health-related social supports, and whole person care. And then, so getting into what do we mean by the payment strategies we've been looking at. We know that there are some existing mechanisms today But the 1115 waiver and the Initiative 1 evolution can help us lay some groundwork, do some testing, and potentially identify and overcome some barriers that might get in the way of advancing health-related social supports. So in lieu of services and value-added services are existing mechanisms within managed care that we can use to really support services that are beyond what's typically paid for through a healthcare setting. And so it can be things like food support, transportation support, education support. And there are many states that are currently really focused on these mechanisms and how to utilize Medicaid funding to address those needs that exist beyond healthcare. Because as we've talked about a lot during this symposium, we know that that's where much of the need exists is beyond the healthcare setting. So payment for these services is currently allowed through managed care regulations, but there are some barriers, there are some challenges that we want to work on. And then, we know that there are some examples where this is already happening, whether outside our state, but also inside our state, where managed care organizations are looking, at new services, recognizing the importance of social factors that impact health. And so it's not to say that this doesn't happen, but there's incredible room for continuing to explore and to build upon, and we think, just to increase the level of support that's provided through these kind of new innovative payment mechanisms. And then, so I mentioned in terms of how does it fit within the 1115 waiver, we think that the waiver authority can provide capacity funding. We can try to test some new service areas. We can also just build upon the partnership between ACHs and MCOs and community-based organizations to have conversations around what are the needs, and talk to communities about what new supports are really critical in different communities. And so there's an opportunity for funding, but we're also keeping the door open on, are there policy barriers that should be addressed, things pertaining to rate setting, or different challenges that could present. The more we discuss and implement, we might run into some of those barriers where we can then have conversations with our federal partners about policy flexibilities. So let's jump to the next slide here. Just in terms of timeline, I think we're gonna go to discussion here in a second. But just so you know, we are working on the renewal application, the full renewal application, which is what Michael covered. And sometime in mid-2022, we plan to submit. That date's being discussed right now, and we're gonna finalize that submission timeline with our federal partners. But yeah, we have a few months here to really continue developing these concepts. We're going to continue talking with our partners, discussing internally, talking with other state agencies, and there will be a lot of opportunity for public comment and involvement even in the months ahead. So we'll be communicating more when we have opportunities for webinars and review of application materials, etc. So more to come.
Thank you very much, Michael and Chase. Feel free to add questions to the question and answer at the bottom of the screen. Right now we're going to have a discussion with our panel. I have about 5 questions that I will ask to begin with, and then we will take the questions from the audience. So to begin with, this question is for Michael and Chase to start out with. Tell us more about what you've learned about the role of ACHs over the past 5 years, and why you want them to continue to be a strategy as we move forward.
Thanks, Linda. I think the main thing that I've learned is just the value of having a partner in the local communities. It's just invaluable. I think, especially thinking about the discussions that we've had in this symposium, there are things that the ACHs can do in responding to the immediate day with what we had with the pandemic. I can't think of one ACH in the last year that I didn't hear about a vaccine hub or information about vaccines or something about coordinating information or knowledge about testing and vaccine. And that's really important. And then when you think about the session that we had just before this about the assessment of integration, that's for the future. And so then where do we go? So having a partner that you can work on with day-to-day concerns and also plan for the future and have that sense of what the local priorities are, to me is just invaluable. And I don't know how we would have the credibility we have with our federal partners if we couldn't talk about the structure that we have locally in Washington State to say, here's what we know, here's what we learned, here's what's working, here's where we need to look for some improvements. Chase, anything, please?
Yeah, I think that's great, Michael. And I would just add, I think back to some of the ACH meetings I was able to attend in the first couple of years of implementation, and the comments that I would hear from partners that I think is still true today, but it's more built in and ingrained in our system because of the value of ACHs. But just the fact that partners through the ACHs make connections that otherwise weren't made, the coordination that happened across sectors, but also across communities where there just wasn't a forum for collaboration at that scale. And hearing that from partners was pretty exciting. And I think now that's just part of the way that we work. That's how we see the ACHs, and we know anytime we need that convening and that collaboration, we have a mechanism to see that. And I think we can't lose that. So that's where I think that partnership is. And when it comes to implementation, opportunities, because our delivery system reform work was pretty unique and the work ahead may look different. But I think regardless, we have to continue to work together and see how connected the system is, or it should be. And ACHs are kind of that mechanism and that glue to implement projects in a more coordinated and cohesive way. So that's what I'd add.
Thanks, Carol, and then Joe.
Yeah, thanks, Linda. So as I recall, and as Chase remembers, the ACHs were really a big experiment, right? They were part of the state's healthcare innovation plan. So that innovation plan included, standing up delivery system reform within regions across across Washington State. I just remember when Jonathan Seed came and visited me personally, he was part of the Christine Gregoire's team, to say, how does your local collaborative work? I was managing the Benton Franklin Community Health Alliance at the time. And I said, just networks work. Getting people together works. It creates action. And the way that the Healthcare Authority has stood up the ACHs by mandate, and when we say neutral, we mean that no more than 50% of the board of directors can be part of the healthcare delivery, the healthcare system. So you had to include other sector partners like housing and transportation and philanthropy and public safety. So all of the ACHs are mandated to have this neutral table where all perspectives could be heard. So I think that has been one of the single most valuable lessons learned from this experiment, is that collective impact, collective action works. It helps communities get different perspectives at the table. Everybody brings their own ideas, and collectively they move things forward.
And Joe.
Yeah, just to echo Carol, I think the neutral convening table is absolutely and has been absolutely critical for our community. I think I've shared this many times. We were sitting with providers and partners that we had been in relationships with for decades, but had never really come to the same table and said, how can we improve and get better at what we do together in the community? And so I'm still scratching my head, frankly, about that one, because just sharing that table together really allowed for so much innovation. Some of the projects that are coming from that innovation are just, they're transformational. And I know we'll talk a little bit more about that today, but definitely to echo what Carol has said, that neutral convening table, bringing partnerships together across communities has been absolutely critical.
Thank you. So I'll ask my second question, and we'll start out with Carol and Joe this time, and then go to Michael and Chase. So what are some of the bright spots and successes in ACHs? Maybe some examples.
Well, if you've been attending this convening, you have heard a lot of bright spots and success stories. I loved the Community Voices panel that started off the webinar with Linda. I think for Greater Columbia, some of our bright spots have been with our behavioral health. Our second cohort were our behavioral health, our community behavioral health providers, and they have been sponges for this information and technical assistance. We've helped stand them up, helping them optimize their EHRs or get them on a certified EHR, just helping them navigate an integrated system. So that has been a wonderful success story. I like to say everybody needs a mother or a coach or an advocate. Our practice transformation navigators have been certainly a bright spot, helping all of our provider organizations learn how to use population health management tools. Collective medical has been such a great bright spot, and I thank the managed care organizations for sponsoring that tool, that population health management tool for our providers. And then we have been really lucky in that we've dove into workforce development. We have a really strong workforce committee, and we started a preceptorship program that has been very successful. Our first cohort was able to graduate 27 interns in various behavioral health professions. And as you know, in these rural areas, we all lack behavioral health professionals. So that has been such a bright spot, and especially during the pandemic when behavioral health needs are so prevalent and so acute. It's been really great to have more behavioral health providers in our region and being able to grow our own under preceptorships from our provider organizations.
Great. Joe.
Yeah, thanks. I'll highlight a couple, and there are so many, but I will highlight a few. First and foremost, I think to some of the points made earlier about COVID, the response was tremendous. I know from our ACH and Pierce, the team really stepped up to say, how do we support the community during a global pandemic? I will say that work is still happening. Just the amount of resource, PPE, assistance that was given to the community, to providers, to the people that we serve was heroic and continues to be heroic. So I don't want to overlook the pandemic that we're still figuring out. I will say that as one of the partner organizations, and I'll switch from my board hat here to a provider hat, we have been involved in truly transformational change to our healthcare delivery system as it pertains to pediatrics. Our organization had the chance to partner with another organization in Pierce County, Pediatrics Northwest. We are 125 years old. They're over 50 years old. We've been partners again for decades, but we came together and we said, we want to do collaborative care for pediatrics. Our ACH said, we're going to provide support and give you the runway to do it right. Well, I'm happy to tell you, 2 years later, we have one of the first fully integrated pediatric physical health, mental health programs in the state. We've done that in partnership with the University of Washington. We adapted the collaborative care model to pediatrics. Nobody said it could be done. We've done it. We've built the right partnerships. We've partnered with Seattle Children's. We've married the right treatments with the right clinical workflows into the right financing structures to make something sustainable. And talk about equity. It's payer agnostic. Every child is served. And we have, during COVID, been diverting kids from crisis and emergency room services and even outpatient mental health services. Not one child served in collaborative care in the pediatric primary care setting has needed a crisis service or an emergency room visit in the past year because of this model. So we're building entire systems of care that didn't exist before, and that would not have happened if it was not for the support of our ACH. We've stood up One Pierce Community Resiliency Fund, looking at gaps and where are funding gaps traditionally missing? Where can we make investments in the community? How do we braid and maximize dollars? Also, how do we set up long-term community assets beyond the waiver, thinking beyond the waiver. And then finally, I'll just mention our community-based care coordination that's been brought up. I can tell you firsthand that our family support workers, through our community-based care coordination programs, we are reaching communities that have traditionally not been engaged in medical care or medical systems because of many things, including racism. We've been able to engage communities and help get care to people who are traditionally not getting it, who are not engaging with medical systems. We're saving millions and millions and millions of dollars by doing that because we're avoiding high cost of care, and the outcomes are tremendous. So I'll just pause there. I could probably keep talking, but those are a few of the successes that we have seen. Thank you.
Joe, I'll add something before Michael and Chase say. I'm glad you brought up PPE, which for those, most people know it's, oh, just had a brain dump here. It's personal protection equipment. And we learned when the state received a lot that it was sent out to the 9 ACHs in like a 2.5 week period. Over 4 million supplies were sent across the state. I don't think that could have happened if it weren't for ACHs. I remember actually being at the airport for a meeting with Carol, and she got a phone call as we walked back to catch the airplanes. And she said, oh my gosh, I'm gonna have to get a warehouse to store all that. And then in my region, which is one of the smaller ones, my executive assistant said, oh, we'll put it in my garage. Well, she had to empty everything in the garage and fill it up with PPE. So those are the kind of stories that you remember. So Michael and Chase, please add to this.
Well, Linda, thank you. And I think what I'd probably start with is to take off from where Joe was talking about and just go with health equity and even spotlight some of the things that have been happening in your ACH in North Central in that area, Linda. And we did not necessarily spotlight health equity in the first 5 years of the Medicaid transformation project any more than a lot of other topics. But I think what we've seen is some real successes through what we've done with response to healthcare transformation in the different ACHs, and realize that it really is an area that we can look at for the renewal, especially looking more at whole person care, but more in an equitable sense than we have in the first year. So I would say that is one of the big observations that we've had out of the first 5 years that we think we can carry over into the renewal.
Chase? Do you want to add anything, Chase?
Yeah, I think I just highlight just an example that has stood out to me, kind of unanticipated in a way. There's clear alignment with the integrated managed care work and the work that ACHs were supporting. But I think ACHs stepped up and played a really important coordination and planning and convening role in the move to integrated managed care across the state. And we were able to meet our required statewide implementation date. And anyway, I think just a lot of really important conversations, a lot of really important coordination, and ACH has stepped into a space where I think the need presented itself, and just we're able to navigate that with partners really effectively. So that's just another example I would throw out there of a bright spot.
That's great. So I'm curious, a lot's been accomplished, but what do you think is left to accomplish in the future? What's not done?
Linda, maybe if that's open to anybody, I'll go ahead and start, and I would love to hear from everybody else. But I think we've been asking ourselves that question, and of course asking the ACHs as well as we worked with you to plan the renewal. And I think that the areas that we can really go to, I think we can continue to make some good work in the area of integration. We got a good start on it in the first Medicaid transformation project, as Chase was saying, but we really can go further into clinical integration. I think it took a lot of work to create the financial integration with the bi-directional with behavioral health and primary care, but more can be done, and we can also do that in a more equitable fashion. I think we can even work more to tighten the work between what we do at the Healthcare Authority and in the communities with the ACHs. To think that we have somehow figured out this link in only 5 years or 6 years is probably would be sort of overstating our successes. I think we see how important it is, and I think we can actually strengthen those links. And like I was talking about earlier, is that the credibility that we get talking with our federal partners, which is where a lot of our funding comes from, is very strong, because we can talk about, here's what's going on across all the ACHs, here's what's going on in a particular ACH. And it really does move the needle when we talk with our federal partners, because that is a specific example about how the money is working in Washington State. And that is invaluable. And so I think more to do there. I'll leave it to some others. I know that there's always challenges, especially coming out of the pandemic.
Chase, and then Carol, and then Joe.
Yeah, I think I agree with Michael, and then I would just add the focus on health equity and social determinants. We've already touched on that a little bit, but I think our focus, on value-based payment, on integrated managed care, there were and are activities that extend into the social determinants of health. But I think greater emphasis on that going forward. I think we're excited about that potential. So I think continuing the clinical integration work, as Michael said, but also looking at, how do we really start to plan for this long-term move to better address social determinants of health and how that does connect to health equity. So I think that takes a line of sight, years out, not just what are we going to do next year. So I think that is a body of work that we can continue to focus on.
Linda, I'm so glad to hear Michael and Chase acknowledge that change takes time. 5 years has just gone by like that. I can speak as an outgoing ED coming on Monday, that some of the lessons learned is that, in order to make change, it takes building trust within a community, right? You have to create, it's all relational. You have to create trusting relationships, and that takes some time. So I'm really glad to hear that the healthcare is acknowledging that fact. But also just the fact that value-based payment, you can't have delivery system reform without transforming your payment system. So the ACHs have been working really hard at transforming the delivery system, getting into provider offices, working on change plans, getting them to change their work processes. But until there's that incentive at the end of the line, at the end of the day, that value-based payment structure is so critical. And so I really encourage the Healthcare Authority to look at our rural providers who are not getting those opportunities for value-based payment contracting, because they are delivering on quality. We are making sure that they have the resources and the infrastructure that they need to deliver quality for their patients. And so our program, our patient-centered medical home program of work, has really elevated the quality of the care that the patients are getting. We can see those numbers in the Healthier Washington dashboard. We can see our ED utilization declining. We can see hospital readmissions declining. We can see follow-up care increasing. So we are hitting those measures, but until the Healthcare Authority really kind of puts a little bit of pressure on the managed care organizations to deliver on VBP in our rural areas, I think that we're missing the boat. So that's one lesson that I would like to leave the Healthcare Authority, is just keep on driving that VBP contracting.
Thanks, Carol. Joe.
Yeah, a couple of things. I think, I think this is, I've been describing the ACH opportunity is an opportunity of a lifetime, really, to think about, to get into, to work this deep in a transformational way. We got to get it right. And it takes time. And so when we talk about things like health equity and building anti-oppressive systems, that's lifelong work. And so we're not going to do that in 5 years, but we can lay the groundwork and build the foundational aspects of those things moving forward. No one should have to ever wait to get the health care they need or the mental health care that they need and end up in crisis because of that. And so we have an opportunity to continue to get that right. I think I'll echo the value-based payment financing. That's the next phase, as Chase described earlier. I think we're on the cusp of greatness with some of our projects that we've seen and the outcomes that we're seeing. I think we try a lot of things often and we say they don't work. But what I'm learning is with time and energy and effort and focused effort and support with dollars behind that, things can work. And so I think we're quick to dismiss things that actually can work very quickly before we actually really do invest in them. And then we're on to the next thing and the next thing and the next thing, instead of really being intentional about what we're trying to do. And so I have seen real change because of that intentionality and the time and energy and effort that it takes. And I'll just finally add that, we're trying to build systems that make the old systems obsolete. And so there's some systems that we really might not be able to fix. But we can build new systems of healthcare delivery that make old ones obsolete. And that, I think the example I gave earlier in our pediatric work is actually doing that. We're making the way we've been doing things obsolete because the way we're doing things is getting the results.
Thank you. So due to time, let's have our next answers to the next couple of questions just kind of be brief, because we do have about 4 questions from the audience that I want to make sure we have time to get to. So going forward, what role does the state play in addressing social determinants of health needs and health-related social needs?
To be real brief, Linda, I think the best thing we can do is find a consistent financing mechanism that emphasizes the social determinants of health. I think there's strong evidence that they're needed in communities and it's needed to wrap around the clinical care. But I think that would be the number one thing.
Thanks. Chase?
I think that's good, great, Michael. And I would just add, I think we're looking at, and the state can help with measurement. So how do we consistently measure and track progress, and how does that relate to payment through incentives and accountability?
Thank you. Carol, this is your thing.
I know. I would just caution that not one size fits all, so just caution that the brilliance of this program has been the flexibility that the Healthcare Authority has given to all the ACHs, and we have all figured out ways to deliver social determinants of health. In our region, we have financed 7 local health improvement networks. They're like mini ACHs, governed and structured very similar, and we allow them the flexibility to really understand, how to deliver social determinants. They understand the community, they know the needs, and so we just support them and provide them some resources. They work with a third-party administrator or the foundations to really drill down and get those dollars where they need to go. So I think local health improvement networks and having flexibility and local voice is really important when you're addressing social needs.
Jill.
Yeah, just very briefly, we're seeing the conversation shift, I think. I think the initial thinking that I witnessed was that this was all about medical care or clinical care. And now I think a few years in, we're changing the conversation to be more about wellness. And I think our community is really seeing that 80% of good health outcomes are non-clinical. And how do we really bring those things together and get the right people around the table to look at the whole picture? And I think that conversation is starting to shift in a positive direction.
Thank you. So this is my last question. I have to read it because it's got 2 parts. So we've been talking about the value of the local voice through ACHs, but what about the need to move statewide approaches on some of these initiatives? How might we see more shared approaches across the state in the future?
Chase, I'm going to be very brief and send it your way, but I do think we can accomplish 2 things, Linda. We can keep the nimbleness at the local area, because I think you and Carol and Joe know how to implement in ACHs that are very different. But what we can do is probably look to what we've done over the last 5 years and find some common areas that we should really be focusing on statewide. And then again, keep that ability to know how to prioritize and implement those common ideas in the local ACHs.
I would just be really brief. We would just add to that, Michael. I think thinking about where that local flexibility makes a lot of sense and is so valuable, but also recognizing that some of the policy challenges or the payment challenges really benefit from more consistency in how we define goals. It kind of relates back to what I was just mentioning on measurement and how we define payment mechanisms. So I think in some ways there's the reality of those opportunities that really do require us to take a look at more unity, I think, and more commonality.
I see this happening naturally, Linda. As you and I know, is that some ACHs gravitate, like your collaborative and our collaborative are very focused on whole person care. So you're already finding alignment within ACHs and work that's been very successful. So I think just aligning along those successes, the behavioral health preceptorship program is a great example of how the state is kind of aligned around a possible workforce development model that works in building behavioral health providers. And we're already borrowing some information from Better Health Together. ACHs are eager, I think, to do what works and what's successful in every region. And so as we collaborate on those ideas, it might look a little bit differently in every single region, but we're all moving towards the same direction, which is the whole point of collective action.
Joe?
Nothing to add. What Michael said, what Chase said, what Carol said. It's exciting to begin collaborating statewide. I've been on the board for a couple of years, but new to the chair role. And so to now start to see this from a statewide perspective of how we all connect across the state is very exciting. And we're excited to roll up our sleeves and continue to do that.
Thank you. I mean, just listening to the first 2 days of the seminar symposium, I think what I really heard from local people were the trusted relationships at the local level. That just kind of gives us speed to move forward quicker. That's been very obvious. So we have 4 great questions from the audience. The first one is, how is the Healthcare Authority reviewing ACH's effectiveness? Do the regions still work? Are they the appropriate group to continue moving forward?
Linda, thank you. I mean, we are always, and take the last part first, we're always thinking about whether we're doing the right thing. And that's, whether we're working with ACHs or managed care organizations, I think we have to be thinking about that constantly. And actually, I've appreciated the conversation over the last 6 months as we prepared for the renewal with the ACHs, because I think you and Carol and Joe have been involved in a discussion about that. But how we are gauging ourselves today is we do have a consultant that's an independent assessor that does take a look at the performance of the ACHs. So it's not the Healthcare Authority that's coming in and trying to justify that the money is spent well. It is, like I say, an assessment that is done by an independent firm that is expertise in these topics. And they provide us with very good advice. For example, they consistently tell us that we're doing well with integration, even though the numbers for behavioral health statewide are not so great clearly because of the pandemic, but they talk about that approach with emphasizing behavioral health has worked, as well as opioids, attacking the opioid crisis. The areas that they tell us we're not doing that we need to do more in is workforce, and doing a better job of building something like a community information exchange to support care coordination. So again, we get a very well-rounded review, and I would probably say it's a review of the Healthcare Authority as well as the ACHs, because it's a collective effort.
Thank you. Anybody else on this one? Okay, the next question is, how does the Medicaid waiver support the multi-payer payment reform for primary care? This person said, I can see how it could, but I think strategically we need to be more explicit of how all of these activities come together.
Let me start again, Linda. I couldn't agree more with that assessment. I think they will work well, and I have to compliment the people in my organization who have decided to take on a renewal at the same time that we need to push more for the multi-payer primary care, because ACHs can wrap around the primary care services that are done in the clinics, and we can emphasize, even ACHs can emphasize primary care and the successes of it even more. And all you have to do is look at Greater Columbia and what Carol has done there with the patient-centered medical home as one way of going about it.
Any others?
Yeah, I would thank you, Michael, for that acknowledgement. We have invested a lot in our primary care system. We like to say at Greater Columbia that primary care is the quarterback of the healthcare delivery system. And so investment in primary care, and that really bore out during the pandemic. You know, fee for service was just not there for our primary care providers. So having that that emphasis on primary care and upholding their needs and allowing them to work at the top of their licensure, all of those ideas that are born out in a patient-centered medical home model of care has been really instrumental in our success.
Great. Joe, do you have anything you want to add to that?
I'll just add from the pediatric lens, we're hearing the same thing. Providers are working at the top of their licensure for the first time in 30 years. It's contributing to workforce. With the level of care we've been able to put into primary care around integration, we can now leverage that to then have some of those higher level conversations. And so it's exciting to begin talking about that, I think, with our health systems on a larger level.
Thank you. So the third of the four, I guess we've got 5 questions now. So this is number 3. What methods will be used for community engagement for understanding needs for the waiver for the future work?
Yeah, Linda, one of the places that we have to think about is that we have moved out the due date for submitting our renewal. And with that, we have more time. And so this gives us a chance not only to connect with ACHs, but also to connect with key stakeholders around the state. You know, for example, in this particular symposium, you know, who have we heard from a lot? ACHs, well, not so much, really your community partners. They've been highlighted in pretty much every panel. This gives us a chance to connect more with the community and also to work closer with MCOs, with some of our sister agencies like Department of Health and ACHs. But I know that you have a perspective as an ACH of what your communities need, but so do your partners. And so we'll need to listen a lot closer before we get this renewal wrapped up.
Any others?
Not sure about methods. Greater Columbia has, I think I talked a little bit about the 7 local health improvement networks, Linda. And so that helps us keep that information, that on the ground, boots on the ground information flowing through Greater Columbia, which informs our work. We also do a lot of community engagement through our leadership council. So we have a regional meeting every month where we share information with our audience, with our participants. And actually Zoom has been really facilitating that. So one of the lessons of the pandemic is the success of telehealth, but also using Zoom to engage more community. I think just supporting more community engagement efforts within our communities, helping stand up vaccine clinics or supporting organizations that are already doing that work. We are just trying to find places where we can play a supportive role, not necessarily a leadership role in all cases, but helping stand up organizations that are addressing diversity, equity, racism. That's where we find, you know, the best bang for our buck, so to speak, is just supporting those organizations that are already doing a lot of community engagement work. For example, communities and schools would be, you know, another bright spot.
Thank you. Any others?
We have, in Pierce, have stood up a community advisory council made up of diverse communities across our community. The chair of that council has a seat on the board, and they have a dedicated time every board meeting to talk about what's happening on the ground. I think listening is another strategy we need to continue to use. Oftentimes we think we know because we look at data, but lived experiences and stories are just as important as data, and bringing those two things together, I think, is important moving forward.
Thank you. So the next question is about area agencies on aging. And so Carol, that's probably for you and me. And the question is, how do ACHs work with them now and how will they go forward? And I would start out with by saying that we have a representative on our board from our local area agency on aging. And early on, I just needed a little bit more background on health homes because they were very involved and they still are in the health homes program. So again, I would say that area of expertise, we can learn from each other, and they're a valuable partner in ACHs.
Linda, I'm going to yield to my partner at Elevate Health because I know you guys have a tremendous health home program. So Joe, if you wouldn't mind answering that question, that would be great.
Yeah, and I'm sorry I don't know a ton about that, and I'm going to defer to our team who's not here, but I can get information and get that back out. I do know we have a health homes program, and it is probably above my pay grade to talk about. So I don't, if I tried, I wouldn't do it justice, but I can certainly get information back out about that. We also do have long-term aging representation on our board as well. But in terms of the program, I'm sorry, I'm unable to speak to the details.
Okay, well, due to the time, I think we're going to have to wrap this up. This has really been
Senator
a fun
Parlett?
session
Senator-
to be
Senator
involved with.
Parlett?
Yes.
A
Did you have
point
a
of
question?
a point of privilege for
Sure.
Chase and I, if you don't mind. Chase and I have two comments we'd like to make
Sure.
before we leave this session. Chase, would you mind going first?
Thanks, Michael. Yeah, Carol hinted at it. She's retiring this month. And Carol, just want to say thank you so much for your work. I remember back in 2014 visiting you at the Benton Franklin Community Health Alliance office and have been able to work closely with you since that time, and just so appreciate your leadership. There's been ups and downs, I know, some that we see and some that we don't see. And so thank you for your commitment, and we wish you all the best in retirement. And yeah, just want to say thank you so much for your leadership, Carol.
Thank you. Kudos for sure.
And Carol, thank you. Linda, we are not going to close this without a very heartfelt and large thank you to you. Your leadership in this North Central area could not have been more timely, and we could not have asked for a better CEO of that area than you stepping in. And I have to, my hat's off to you for the grooming that you've done to have some real transition in that area. It's been very impressive to see. And for everybody else, I know that they know this, but I'm going to say it again, your leadership in the Washington State Legislature, primarily in the Senate, was significant for so many of the access, quality, efficiency measures they live on today. You know, we're going to miss you, but there's no way we're going to be able to forget you and Carol, because everything you've done is going to live on. So thank you so much.
Wow, thank you very much. Heartfelt, I feel it. Thank you. So I would like to close by actually something that Nathan Johnson, as you know, he was very involved in helping set up this grand experiment. And because North Central ACH has physically moved to a new location, and I'm such a pack rat, I threw a lot of stuff away, but there's something that I didn't throw away. And this goes way back to when the whole beginning started. And I asked Nathan, I said, Nathan, how are we going to determine if ACHs are going to continue? And this is what he said. It's a test to drive value. And if enough value is demonstrated, we'll have to figure out how to sustain them. And I think that's where we are. We've already figured out there's value, so much that we need to continue this, because as Carol said, 5 years is not long enough. But those were the right words a long time ago. I'm so glad I didn't lose them. So what I would like to say, the next session is going to be our last session for this 3-day symposium. You won't want to miss the keynote speaker. Her name is Yolo Akili Robinson. And so we will stop right now. We're just 1 minute over time, and we'll see you in 15 minutes. Thanks to all of you, and thanks for your kind words.
Thank you all.